Thank you for joining us for tonight's educational webinar on carpal tunnel syndrome. Tonight's speaker is Dr. James Cassandra, OrthoNeuro, orthopedic hand and elbow surgeon. Dr. Cassandra is a board-certified and fellowship-trained orthopedic surgeon specializing in hand and upper extremities conditions, as well as general orthopedics, fracture care, and trauma. Please type questions in the Q&A box below, and Dr. Cassandra will answer questions following his presentation. Dr. Cassandra?
You can go ahead and share your screen now, Dr. Cassandra.
Okay. Right, I think we have it. My name is James Cassandra. I'm orthopedic surgeon. I did a fellowship in hand and upper extremity surgery, and I've been practicing since I've graduated to my fellowship in 2005. I've been with OrthoNeuro several years and continue to practice, and we love taking care of patients. And carpal tunnel is a condition we see quite a few cases of, and it's a condition we can make a significant difference in patients' lives. So I thought this would be a great opportunity to lay out some ideas and perspectives and thoughts on carpal tunnel. And if any time or at the end of the presentation, if there are any questions, I'll be glad to answer these. But we'll start going through this presentation now, and we'll go from there and start off. Here we go. So what is carpal tunnel? I get this question a lot with patients, and it's I'm sure everyone in the audience has heard about carpal tunnel. Carpal tunnel is a compressive neuropathy where the nerve, as the median nerve comes into the wrist, it gets pinched right in this region. So when that happens, it can cause numbness, tingling, and pain into the hand. Some patients complain of numbness at night where they can't sleep, or pain that radiates up the arm. So the symptoms aren't always one symptom. It can be a combination of different symptoms, and different patients are affected differently. So the carpal tunnel syndrome it's definitely a pinched nerve, and then it all comes down back to the anatomy that we've learned in medical school. So the carpal tunnel is actually a tunnel. So when we take a cross section, we have a tunnel construct, and through that tunnel, we have nine tendons that go through there to the fingers and thumb, and then we have the median nerve as well. So through that, the nerve sometimes can get pinched. That tunnel or space has a pressure. That pressure is anywhere, from a few millimeters of mercury. If the hand is at rest in a neutral position, it should be maybe 2 millimeters of mercury. As the wrist bends down and has stress going across it, that can lead to more pressure. It sometimes can go up to 30 millimeters of mercury. As there's more compression in that space, for whatever reason, sometimes the pressure even goes up to 90 or 100 millimeters of mercury, and it can lead to compression or pinching on that nerve. So the borders are the bony constructs of the carpal bones, and then the roof, we call it, of the carpal tunnel is the transverse carpal ligament, and then the nerve sits in that region. So in 1854, the first carpal tunnel case was described in the literature. It was a patient who had a rope tied around the wrist. It didn't result in a good outcome. The patient ended up with an amputation, but this was a first description of where the nerve gets pinched or compressed. The second case was associated with a fracture, which we see commonly today as well, and it led to carpal tunnel syndrome, which they treated at that time in a splint, and it improved. So those are some early cases, and that was 1854. So, a few, more than 150 years later, treatment has changed slightly. So the risk factors for carpal tunnel syndrome, being female, or female patients have a higher risk: obesity, pregnancy, hypothyroidism, diabetes, rheumatoid arthritis, gout, other inflammatory conditions, chronic renal disease, smoking, alcoholism, and patients with repetitive motion. So how do we prevent carpal tunnel? Can it be prevented? We like to think things can help. It doesn't always cure a carpal tunnel case that starts, but working, take breaks. You have to relax on your grip. Grip with tight flexion on the wrist and a tight grip, that can put more pressure on the carpal tunnel. So if someone's doing that all day, every day, it can lead to some irritation of that nerve. So take breaks, watch form, and always remember ergonomics and posture. Sometimes patients have to change it to more ergonomic keyboard or mouse, and keeping the hands warm can be helpful. So patients often come in for a medical evaluation, and we start with the diagnosis. We always want to take a history. We ask the patient the pattern of their pain, discomfort. Classically, with carpal tunnel, we see pain symptoms getting worse at night. Many patients have trouble sleeping at night, or they have troubles with other activities such as driving or being on the keyboard using their iPhone. The symptoms oftentimes are numbness, tingling. They go into the radial border or aspect of the hand. So it's usually the thumb, index, and long finger. And then the radial border, the ring finger, can be affected as well. Those are the classic areas. Not everyone reads a textbook, or their symptoms aren't always textbook. So examining the patients and taking this into account is important. The physical exam, one thing we always look for on severe cases, there's thenar atrophy, where the thenar muscle, or this muscle right here, it can shrivel up. That can happen when the nerve is compressed with a severe case of carpal tunnel. On the physical exam, Phalen's test, Tunnell's test, Durkin's test, median nerve compression tests are all common things we do to assess the median nerve function. So here's a Durkin's, or median nerve compression test. It's putting pressure on that nerve. And if this recreates symptoms, it's considered positive, and also it's considered the most sensitive test. The Tunnell's test is tapping over the nerve at the site of compression. If that leads to an electric tingle or electric signal that shoots down the fingers, that would be a positive Tunnell's test. The Phalen's maneuver is flexing the wrist and holding this around 60 seconds, and that oftentimes can recreate symptoms. The Semmes-Weinstein monofilament test is touching the fingers with different size fibers and seeing the response. So oftentimes we obtain x-rays to look for other conditions and see if there's other changes going on in the wrist, such as any bony tumors, osteoarthritis, prior fractures or malunions, which can put more pressure on the median nerve. And after x-rays and exam, oftentimes we obtain the gold standard examination is the EMG nerve conduction study. So the EMG, we usually have the neurologist do the study, and then they check and see how the nerve is conducting the signal. If the signal slows down, I think of it just like traffic on the highway. If there's an accident or a lane closes down, and that's my analogy to compression, traffic will slow down. So the same with carpal tunnel. When the nerves pinch, the normal nerve signal that travels down the nerve slows down. So we can pick that slowing up and grade carpal tunnel. Here's an x-ray. This is a carpal tunnel view. You can see some of the bony landmarks. It looks normal. Here's a image of an EMG study being performed. There's in the literature, there's always talk of what studies have to be done. The EMG is a study that I feel most times is done, but someone with classic symptoms and a patient that may want to avoid that study, there's literature to support that this could be done and go straight to treatment. I think the EMG nerve conduction study is nice to have before anyone goes to surgery. It gives us more information, and sometimes we find other things going on and not just the carpal tunnel. So other things in the differential diagnosis are compression of the median nerve higher in the forearm. It's called AIN compression syndrome. Parsonage-Turner syndrome is inflammation or inflammatory condition that can affect and cause nerve symptoms. Pronator syndrome can cause symptoms like carpal tunnel. And oftentimes I see patients with cervical radiculopathy or pinched nerve in the neck, most classically at C5, C6, and this can lead to what we call double crush syndrome, where the nerve is pinched in the neck, and then that nerve has a higher chance of getting pinched at the carpal tunnel. Ulnar neuropathy oftentimes can go along with carpal tunnel syndrome, what we call cubital tunnel syndrome, and there's peripheral neuropathy, which can be common in our older population and diabetic population. So treatment for carpal tunnel, it varies. It depends on the severity, the grade, and so examining the patient, seeing what their symptoms are, reviewing the x-rays and EMG all can help make a treatment plan. On mild cases, non-operative treatment is usually the mainstay, and that's how we start with anti-inflammatories, splints. There's a cock-up wrist splint, which keeps the wrist at neutral position, and the pressure on the wrist is minimized. So we want to keep the pressures in the carpal tunnel low, and that's the thought of using the splint. Most times this is done at nighttime. We want to have our patients avoid curling the wrist up when they sleep. Going into that fetal position is hard on the carpal tunnel and the nerves. So the splints can be helpful. Nerve glide exercises, they're simple. Therapy can be done. The nerve glide, I show patients, it's pretty simple, where you put your arms straight and pull your fingers back, and you feel that pull down through the carpal tunnel. And then the same with the wrist and fingers going on the dorsal aspect and pulling them back. And you can do this with the fingers going towards the floor and to the ceiling. And that stretch tries to get more oxygen to the nerve and take some pressure off the nerve after the nerve glide is complete. Modifying activities can be important. I see many patients who have a job with repetition. If they change their job or take a break, sometimes their symptoms get better. And the other aspect of non-operative treatment is invasive. It's a steroid cortisone injection. We place this in the carpal tunnel, and this often can be diagnostic and therapeutic in our patients. And then if the non-operative measures fail, we start to talk surgery. And the two main standards are the open carpal tunnel release and the endoscopic. Here's an example of the wrist brace. Some nerve glide exercises. Cortisone injection going in the wrist. This injection, it's easy to do, it's well tolerated, but it's very important that the injection is in the right anatomic location. If the nerve is injected or that needle and injection goes in the nerve, it can be devastating. So it's something that's easy and well tolerated by patients, but it has to be done correctly. The open carpal tunnel release. This is a traditional approach for carpal tunnel. It's a large incision. How large varies on different surgeons, but it can be, I've seen very large incisions by some surgeons. Others, are smaller, but going down, opening those tight structures and decompressing the nerve. It leads to good long-term results. I think the open procedure is good, but the larger the incision, sometimes the longer the healing takes. And I think can be a little bit harder on the recovery. So this is where in our practice, the endoscopic approach has been, I think, very nice. It's a minimally invasive technique. It's a quick recovery. Patients have a good outcome and it's quick, and patients get back to work sooner with the endoscopic procedure. So this is endoscopic procedure is a small incision. We go in through that incision. There's a number of ways to do it. I like a one incision technique. Some surgeons have a two incision technique, but with that one incision technique, we have a camera. We can visualize the transverse carpal ligament, then incise that and decompress the nerve. So here's an example. A few things on this patient were going on, but we'll focus on the carpal tunnel. So there's the diagram. The incision at the wrist is where we'll be operating. This is a bloodless surgery. So we have a tourniquet on the arm. We use an Esch mark. It forces all the blood out of the arm. Then the tourniquet goes up, and then we proceed with surgery. So here's the small incision. Small retractors are placed. Visualization's key. Back we can see the funny glasses we wear. It's loop magnification to give us very clear and enlarged image. So after that incision's done, we have dilators. Those dilators go in. A spatula then frees up the ender surface of the transverse carpal ligament. And then we have this device is called the centerline device. It goes in that small incision, the camera's in it, and there's a blade that we can deploy and use that to incise the transverse carpal ligament. So again, it all comes back to anatomy, being in the right location. There's some studies that show there can be a higher risk of injury and damage to structures using the endoscopic technique. But I think if someone is properly trained, they follow the anatomy, they know where they are. I've never seen a problem with this, and I think it's a great technique. So this is kind of where we're going, right in this region. That incision's coming down between Guillen's canal with the ulnar nerve and the palmaris longus tendon. So we drop it into the carpal tunnel. That goes then in to the carpal tunnel. This is the image we see. And then through that image, the roof is, or the transverse carpal ligament is the white structure. And here's an image of that being incised. So there's a blade that is deployed under my guidance, and then releasing that tight structure, being careful not to damage any other structures, but the transverse carpal ligament in this case is thick, it's quite tight, and it's decompressing nicely there. So it's freeing up, it's almost freed all the way. There's a little more distally. You have to be careful as you go distal. There's branches of the radial artery with a superficial arch that you always have to avoid and respect. So there's the decompression of the transverse carpal ligament. There's a distal fat. So that all comes out. And then even though that part is decompressed from the transverse carpal ligament, there still can be significant tightness or compression on the nerve as the nerve is more proximal to the wrist. So at the forearm fascia can be tight, and every patient, it's variable. Some patients have a very tight, thick band of fascia or compression here. Other times we don't see it as tight, but you always have to make sure it's decompressed. So after the distal release, I go proximal in the forearm and free that up using tenotomy scissors. After it's freed, usually I put glue on the incision site, and that's it. Recovery is quick, usually about 1 week. Patients go into a removable splint. Initially, I like to keep a splint on to protect the wrist and help with the swelling and soft tissue, but the fingers are free, so I encourage early range of motion immediately. Different types of surgery, can have different, cost, and anytime you go to the OR, there's more impact to the environment. But I think going through endoscopic surgery, our goal is for a great outcome for the patient. And I think there's not a big difference in the whole scheme of things if it's going to the OR to do it or another setting. So the outcomes with carpal tunnel surgery, I feel patients do very well, and it's a great surgical procedure to do. Patients have to be selected correctly. I think the outcomes definitely improve with the experience and the longer you're doing it. Patients improve quickly. By 6 weeks, patients are doing very well. Most of our patients at 2 weeks have full motion and their hand is functioning well. The risk of surgery, they're always there. We worry about infections. That's one reason I like to keep the postoperative dressing on a little bit longer and slow patients down with that for about a week. So infections, it's very rare, but can happen. Injury to a tendon or nerve can occur. I haven't seen it happen, but it's something that we always are very careful with. And then one of the more common conditions after surgery, there can be pillar pain, which is some pain or tenderness around the scar tissue. This is different for every patient. Sometimes that tenderness and pain can last for several months. Most times it isn't a big deal. Occasionally, probably less than 2% of the time, a patient may have some tenderness that might last a few months, and it can be just a little bit harder for the patient to recover after with some painful scar tissue and pillar pain. But with therapy, massage, and modalities, this will resolve. So overall, patients do well. Recurrence rate is very low. It's less than 12%. I feel it's even less than this. And our goal is having a happy patient who gets their function back, who gets their feeling back, and can use their hand and not have pain at night or pain and discomfort when they're trying to do their daily activities. Thank you. Any questions?
Yes, it does look like we have a few questions. I'll start at the top and we'll go from there. Is numbness in the tip of my middle finger carpal tunnel?
It could be carpal tunnel. Just having numbness on the tip of the finger, the middle finger, carpal tunnel definitely would be in the differential diagnosis, but there's other conditions that could cause that. A pinched nerve in the neck, neuropathy. There's some other areas where a nerve could get pinched, but carpal tunnel definitely could be one of the probably more common diagnoses we see for that symptom.
Okay, next, how bad do the symptoms need to be before you need surgery?
You know, everybody's different with their pain and how much they tolerate and their discomfort and symptoms and how their body senses the environment. You know, I have some patients with severe carpal tunnel. Most people, the typical patient would have severe symptoms of pain, discomfort, but every now and then you have a patient who has severe changes and not much pain, but is starting to have nerve damage. So, you know, a patient like that, you'd have to, even though their symptoms per the patient's perspective aren't horrible, with their nerve damage, you'd have to be aggressive and treat that with surgery. There's times there could be a mild carpal tunnel per the EMG that isn't a mild case. You hear mild and you think it's not bad, but a mild carpal tunnel sometimes have severe symptoms, which is causing quite a bit of pain and dysfunction and difficulty performing activities. And, you know, pain at night, numbness, tingling, clumsiness in the hand, and those are all classic symptoms. So it's patient dependent, but, you know, that's why it's so important to evaluate patients, you know, do a physical exam, review the imaging and EMG studies to put that whole picture together. So I think so it helps guide our treatment and make the correct decision.
Okay, can carpal tunnel syndrome come back after you have surgery?
You know, there is a recurrence of carpal tunnel. I feel it's low, it's, you know, I do see it come back, and I see it come back in sometimes patients who had surgery years ago, you know, like 20, 30 years ago, and then they've developed carpal tunnel again. So that's one patient population. And another patient population is diabetic patients or factory workers. With diabetes, sometimes the nerve just has a tendency to be more sensitive to and have more inflammatory changes around the tendon. So in those patients, it can recur. It's probably less than 5% of the time that the recurrence can happen.
Okay, what if my symptoms are in my little finger?
Little finger is usually not typically carpal tunnel syndrome. Like I said earlier, not all of our patients follow the textbook. So occasionally I find patients who they present with symptoms that aren't always classic. Most commonly, I would say numbness in the little finger wouldn't be from carpal tunnel, but it's not impossible. That would probably be more associated with cubital tunnel syndrome, or where the ulnar nerve gets pinched at the elbow. But that's again why the physical exam and, you know, taking the history and physical and the studies are so important to, you know, put that whole picture together.
Okay, what if numbness is in two fingers, such as the thumb and the pointer finger?
That definitely could be carpal tunnel. Yeah, that could be, that follows that median nerve distribution, and for sure it could be carpal tunnel.
Okay, does a nerve test hurt?
Again, everyone's different. I've had it done, you know, more than once, and it's not something I enjoy doing, but I didn't think it was a big deal. I do have patients who, you know, who complain about some of the discomfort from it. I find the majority of patients get through it without an issue. But it's something you wouldn't want to do every day, I'm sure.
Okay, do pinched nerves in the neck mimic symptoms of carpal tunnel?
Yes, I do see that happen. I've seen patients before who if I had to bet, I would think they had carpal tunnel. And then we get that EMG nerve conduction study, and it shows it's a pinched nerve in the neck. So it's not very common that happens, but I can remember one case that it was a nurse, an OR nurse that I worked with, and her history, physical, her exam, it all pointed to carpal tunnel. But when the nerve study came back, the most significant finding was the pinched nerve in the neck, or cervical radiculopathy. I do think when the cervical radiculopathy happens, though, as a nerve is pinched in the neck, there's a normal axonal flow of the material that has to go down the nerve and send the signal. So when that happens, any area of irritation downstream can cause more sensitivity. And that's what we call double crush syndrome. So with the cervical radiculopathy, when you have that, I think it's easier for a carpal tunnel to develop. But I think these studies and the EMG definitely can help clear up any questions. The EMGs are good, but they're not 100% either, or 100%, in telling you the whole story. It's a clue. I feel our job is being like a detective, and we have to take all these clues and put them together, and then guide patients on the correct treatment.
Next question. How long can I wait to have surgery?
It depends on the severity. If you have a moderate or definitely severe carpal tunnel, it can start leading to what we call axonal loss, or bottom line, that's nerve damage. So in those cases, I think doing it sooner than later is the right idea. If you wait too long in those cases, it can lead to muscle, we call it thenar atrophy, or where that muscle shrivels up. Once that happens, it doesn't always recover. It can improve some of the pain and the discomfort, but some of the permanent nerve damage may not come back. So in the moderate to severe cases, doing it sooner. If it's a mild case and it's not causing very much symptomatology and conservative care helps, it's something that you could probably sit on it for a while. And over time, those carpal tunnel, it typically waxes and wanes depending on activity, other, life stressors, things that are going on with the hand and activities. So depending, sometimes I see patients where that carpal tunnel is getting really bad, then as they do the conservative treatment, the pain and discomfort and symptoms go down. So, and then over time, it may stay down, but it could come back. So it's something, every patient's different, and using that nerve study and listening to your body are important.
What is the recovery time following surgery?
Recovery time, I feel by 2 weeks, patients are doing really well. I've worked with surgeons that were back within a day or two to work. I wouldn't recommend doing, pushing it that much, but I feel by 2 weeks, most patients are doing well and are back to most typical jobs. If someone is a roofer or is a factory worker on the line, so it may be up to 4 to 6 weeks. They need to get that fully recovered to be safe to go back. But most times by 2 weeks, I feel patients are doing really well.
If you have thumb arthritis, would it be possible that the edema from the joint be a cause of the nerve impingement? And if so, would you need surgery for both the thumb and CTS or just one?
Again, those symptoms can, the hand is a area where a lot of things can be going on in a small space. So I do see a lot of patients who have carpal tunnel syndrome and arthritis or tendinitis, or sometimes all three. And, they can happen. And I do have patients who, there are times we have to address the carpal tunnel and arthritis at the same time. Other times we were able to just focus on the carpal tunnel and then treat the arthritis more conservatively.
What is compressing the median nerve when CTS recur? You have already cut the tunnel fascia.
Yeah, you incise that tunnel, so the tunnel is like this. You incise it, and that it allows that to spring open and take the pressure off. But your body will form scar tissue. So over time, that transverse carpal ligament will heal with scar tissue, and you'll have a new roof of the carpal tunnel. It'll be the transverse carpal ligament that's inside. So the structures in the carpal tunnel, remember I said we had 9 tendons. The probably most common thing are where the tendons can have tenosynovitis or inflammation around. And if that happens, each tendon has a little inflammation that fills that space. It's like, putting a few socks in your drawer, but then, that space, then you stick another pack in, and then it's hard to shut that drawer because the space is getting filled up. And the same with the tenosynovitis, it can put more pressure on the median nerve. So that's a common thing. Arthritis, sometimes there can be inflammation from the wrist joint and bony spurs that can compress down on the carpal tunnel too.
Okay, and last question is, will it ever fully go away once you have it?
Once you have carpal tunnel, I do think it can go away. And it depends. Sometimes I see a young patient and they develop it, and then they modify their activity, and they change their job, and their carpal tunnel symptoms go away and they're happy. And then I see patients who the conservative care doesn't work and they go on to surgery, and then their symptoms go away. So there's more than one way for it to go away, but I do think it's possible for it to go away in 99% of the patients. There could be that 1% or less that even with surgery, there could be some still residual nerve irritation just based on how severe it became before they did surgery, or other nerve associated conditions such as neuropathy, diabetes, that can affect the nerve.
Well, okay, that ends the that ends the webinar for this evening. Dr. Cassandra, thank you for participating in tonight's webinar. Our next webinar will be held on September 5th. Dr. Rodney Komisar will be speaking on shoulder instability. Enjoy the rest of your evening.
Thank you for your time. I appreciate it. And good luck, and be safe this summer. Thank you.
Thank you.